Okay, so any questions before we begin the Kahoot? Has anyone been in my office when I haven't been there recently, though? I do need to ask that question. I noticed my antidepressants are missing. Anyone want to own up to that? Well, whoever it was, I hope you're happy. Okay. Yeah. Let's get moving. All right, which area of the brain functions in coordinating muscle movements to produce speech? This would be the angular gyrus, this is Broca's area, the limbic association area, or Wernicke's area. Let me think. All right, yeah. So Broca's area is correct. So that's remember when we saw the two videos, the one gentleman who had a stroke that was affecting Broca's area. What was his main issue?
Broken speech.
Yeah, it was very kind of broken speech. He had a difficult time generating the actual words that he wanted to say. His understanding, though, was fine. You know, he could answer questions appropriately. It was just very difficult for him to actually get the words to do so, right? And what do we call that? Sort of aphasia. Like a fluent, I'm sorry, not fluent aphasia, but expressive aphasia, right? So he's not actually able to express the words he's trying to say there. Versus the other gentleman, he probably had damage done to which area? Wernicke's area, right? So is he actually understanding like what questions were being asked of him? Not really. But he could generate words just fine. You know, his Broca's area was totally fine. But what was getting communicated to Broca's area didn't make a whole lot of sense, right, to us. And we call that more of a what type of aphasia? And more that fluent sort of aphasia, you can call it more like a global sort of aphasia in those cases there. So good. So that's Wernicke's area. The limbic association is good for what sort of things?
You said the Wernicke's?
No, the limbic association area. Remember that helping to control things like emotions. That's where we see a lot of vegetative sort of functions there. That's where like the hypothalamus is going to be involved. And then the angular gyrus is kind of helping out with some of the kind of visual information from the visual areas getting transferred over into Wernicke's. Good. Okay. Which of the following is a way that smooth muscle contraction differs from skeletal muscle contraction? Sarcoplasmic reticulum is more developed in the smooth muscle. Calcium is not needed in smooth muscle contraction. Myosin phosphatase is used to remove phosphate from myosin. Or troponin is only found in smooth muscle. Interesting, pretty good split there. Okay, so let's look at this. So sarcoplasmic reticulum is more developed in smooth muscle. That was false, right? Because remember that is where, because again, what influx is normally stimulating skeletal muscle? What generally stimulates that contraction initially? Sodium influx, right? Versus in the smooth muscles, typically more calcium influx, right? So because we already have calcium coming into those smooth muscle cells, you don't have to have as well developed with the sarcoplasmic reticulum. So that's one of the big differences that you're going to find. Okay, obviously calcium is not needed in smooth muscle contraction. It's false because it's absolutely needed. That's what's actually triggering off the actual contraction itself in the first place, right? Now troponin is only found in smooth muscle. That is obviously false because we need troponin in the skeletal muscle. Because what is troponin helping us to do? Well, troponin is going to be good for helping to, one, bind to calcium, and it's also causing those conformational shifts to allow for active sites to be exposed, right? Because remember, we'd have with the actin itself, you'd have things like the tropomyosin. It's covering up those actin strands that prevented, and again, the active sites were just another name for what? What kind of molecules were they? And they're ADP molecules, right? So again, it's going to cause that conformational shift to occur where the ADP molecules are going to be exposed there. So in those cases, you absolutely have to have troponin. Troponin is not really a big player in the smooth muscle there. Now, myosin phosphatase is used to remove PO4 from the myosin. That's absolutely true in the smooth muscle. And in fact, that's what's helping us to cause the actual relaxation thereof, right? Because remember, we have that calmodulin getting activated. That's going to help to activate that myosin light chain kinase. And that's what's actually getting the phosphate group onto the myosin head. And then that can interact with the actin there, right? Versus in the skeletal the skeletal muscle, I should say, what you're finding there is that remember the myosin head itself actually has ATPase activity. So you can have ATP come bind right to it, it'll then cleave it, and that can help to actually regulate that versus having anything to come along and actually have to get rid of the PO4, right? The phosphate. Makes sense? So kind of go back and kind of compare and contrast the activity there. Again, in the end, it's all actin binding to the myosin, causing that movement to occur. But again, the actual way that's regulated is going to be much different, right? Because which one's more efficient as far as the energy utilization? Smooth or skeletal? Definitely smooth muscle, right? Because again, once it's actually bound, it can stay bound for a good long time. You can have smooth muscle being contracted for a very long time. Whereas with skeletal muscle, you want it to be very dynamic. You want to be very kind of quick reacting because, you know, my smooth muscle, I don't necessarily need to be able to do things like, you know, run and jump and all of that, right? Okay. An acetylcholinesterase inhibitor would cause which of the following effects? I'm blocking the activity of acetylcholinesterase. Would I see dry skin? Would I see hypotension? Would I see constipation? Or would I see bradycardia? So I'm blocking an acetylcholinesterase. You should all get it right because we just covered it, right? Okay, so let's work through this. So we have an acetylcholinesterase inhibitor, right? So we have something that's blocking the activity of that enzyme. So what happens to acetylcholine levels? They're going to increase, right? Because we're inhibiting the breakdown, so thus we're going to have increased levels of acetylcholine within all of these little synapses here, right? So does that mean it's going to have increased effect on the nicotinic or muscarinic receptors? Both. Actually, it's going to affect both, right? Because again, I can't just block acetylcholinesterase working just at the muscarinic receptors. You end up seeing effects on both receptors there, because again, you're having much more systemically. Okay, so would we expect to see dry skin? No, because we saw that if you look at secretions in the actual skin, you find those are going to be increased when you have muscarinic activation, right? Because again, we saw diaphoresis occurs with that. Okay, right? Hypotension. Wouldn't really expect to see that because if you go back and look at the effects on the muscarinic side of things as far as innervation of the blood vessels, typically you're going to see that there's really not a lot of strong innervation there. So from the muscarinic standpoint, it doesn't really do a whole lot for us. However, if we're stimulating nicotinic receptors, say on the preganglionic sympathetic fibers, what could that do to blood pressure? It actually increase it, right? And if you go back to the nicotinic effects on the days of the week, HERS day for the ladies was hypertension, right? Anyway, constipation, would you expect to see that? No, because this is going to be much more of a muscarinic sort of thing. When you go back and look at your dumbbells, that D stands for defecation, right? So defecation would be the big thing you're going to see there. A lot of diarrhea associated with overactivity of acetylcholine. And then finally, bradycardia. This would occur mainly due to the fact that you're going to have more overwhelming sort of muscarinic effects here due to the muscarinic activation of the heart. Typically, you expect to see bradycardia. Now, could you possibly see tachycardia? Potentially, right? Because if you go back, what was Tuesday? Tachycardia, right? So again, that could be due to nicotinic stimulation. So if I put that on here, that would also could have been true. But typically with something like an acetylcholinesterase inhibitor, you see much more strong muscarinic effects, especially kind of later on as the patient kind of progress there. But does that kind of make sense? So again, being able to delineate between muscarinic versus nicotinic, and again, looking at the baseline issue here, we're increasing levels by blocking metabolism. Okay. All right. Up next. Which of the following can cause seizures? Hypoglycemia, stroke, electrolyte disorders, or toxins? I'm seeing a few absent seizures occurring right now. Okay.
Yeah, okay.
They're all correct, absolutely. Good job. Again, I can ask trick questions here because I can do that. Right, so any of these could be a cause for seizures. And in fact, when you have a patient who presents, say, to the ER after a witnessed seizure with no previous history of it, guess what? You got yourself a pretty wide differential, right? You need to work through basically a host of different disease states to try to figure out what exactly happened here, right? I also could have put hypoxia on here. That's another big one, right? So oftentimes, especially like from the emergency medicine sort of standpoint, you're doing things like checking their oxygen levels. Okay, if that's good, then you can move on from that, right? Then you're looking at things like, okay, what's their blood glucose? I can do an AccuCheck and get that very quickly. I can rule that out. You can do things like get an ABG, which can give you some ideas on electrolytes and pH, etc. Remember, if you're more acidotic or more alkalotic, which one makes you have a harder time getting a seizure? Yeah, acidotic. So again, being acidotic kind of increases that threshold. However, it's going to all be to only certain degrees. Again, you can overwhelm that, and eventually, it could be a problem you run into there. But toxin's a huge one, right? So again, it could always be what was my patient exposed to that could have potentially be causing the seizure here. Could it be an environmental thing? Was it a drug they took? Who knows what it could be, right? So very difficult to ascertain. Obviously you're going to do a whole lot of things like imaging, like CTs and whatnot, see what's going on. But any of these could be possibilities. Okay. Improperly prepared fugu causes sodium channel blockade, causing which of the following symptoms? Fugu is another name for the pufferfish. It's a delicacy. But it blocks sodium channels and can cause which symptoms? Tachycardia, constipation, rhabdomyolysis, or paralysis. This is for no points. This is just kind of illustrate.
Have you ever seen
Has anyone ever had fugu? I have not, unfortunately. A good job, yeah. So why does this cause paralysis?
Because it's not letting sodium get in, so it's not activating the calcium channels, so no contraction.
Yeah, so basically the big thing you're going to see here is you actually cannot propagate action potentials appropriately, right? So by blocking the sodium channels, I may be able to generate action potential in the CNS, but it can't travel down to places like the muscle. And so, yes, ma'am.
Is that because there's a toxin in a fish?
Yes, I will talk about that in just a second. I'll elucidate what that toxin is. But basically, you're blocking sodium channels from being able to propagate action potential, so that affects a whole host of things. And in fact, when you eat pufferfish, one of the things you look for is actually a little bit of tingling in the lips. That actually shows you there's a little bit of a toxin. It's actually called tetrodotoxin. And so you can look it up. But basically, it blocks the sodium channels. And if you get a little bit of tingling, it shows that, okay, you got a little bit of sodium channel blockade here. But if you have too much sodium channel blockade, right? So anyone see that Simpsons episode? Homer has to go through the 5 stages of accepting his future death because he had improperly prepared fugu. Anywho, you should go watch The Simpsons. Very good show, as it turns out. But it will cause paralysis. And again, paralysis of which muscle is ultimately going to cause the patient's demise? The diaphragm, right? So again, that's a big thing you worry about. Now, you can support patients through that. You can do things like intubate them and kind of breathe for them until the toxin kind of runs its course. However, that's kind of the big thing you see with that. Rhabdomyolysis would occur after what could cause rhabdomyolysis? Probably too much muscle activation, right? So again, after very strenuous exercise, or someone was having, say, a seizure, and they actually were overactivating the muscles, that's where you can see rhabdomyolysis potentially occur. So this would not be the case because they're paralyzed. And then if anything, typically you see more things like bradycardia, more like diarrhea. So again, those are not going to be the hallmarks here. But the paralysis, that's a big thing you worry about when you think of fugu with like the pufferfish, right? But tetrodotoxin is the toxin that is with the fish. All right. What is the function of the Ttubule? Does it produce the elastic protein titin? Does it allow calcium into the myocyte? Does it allow propagation of the action potential deep into the muscle? Or does it attach actin and myosin together via cross bridges? Interesting. Interesting. Yes. So the Ttubule, if you go back and you look at your little diagram there, and actually, let me do paint, because you guys love my drawing skills. So if you were to look at, for instance, say a muscle fiber here, so let's say we got a nice big muscle, right? The T-tubules are going to be kind of going down into the middle of those fibers there, right? And again, the benefit of doing this is that when you have an action potential, say, it gets generated, say, for instance, say right here on the muscle, it's able to just not go around and spread on either side of the muscle, right? It's supposed to be an arrow, which is not going. But it can then travel kind of deep down into the tissue itself. And then by having that propagate, that's where you can have activation of things like those dihydropyridine receptors. And then that can activate those ryanodine channels that allow for calcium to flow out from the sarcoplasmic reticulum. So this allows for much faster transmission deep into the muscle, where you can have activation basically the whole muscle altogether, rather than having just kind of spreading on the outside and eventually kind of trying to go deeper from there, right? Make sense? I actually don't know what actually produces the elastic protein titin. I'm sure maybe there's some sort of titin sort of enzyme associated with that. Allows calcium into the myocyte. That would not be the case there. If anything, maybe that dihydropyridine receptor can allow for some calcium flow. That's not the big thing. Typically, you're going to see more calcium channels located on the smooth muscle, so it's going to be much more important there. And then again, what actually allows for the actin and the myosin to come together? Remember, those myosin heads that are actually going to cause that attraction to the ADP active sites, and it actually causes the actin to move along when you have the myosin head actually kind of fire itself off and kind of move and cause that power stroke to occur, right? Okay. An alpha-2 agonist should cause which of the following? It cause sweating, hypertension, tachycardia, or meiosis. Got to think back, where is the alpha-2 receptors actually, where do they reside? Interesting. Okay, so let's think about, where do the alpha-2 receptors predominantly lie? These are going to be mainly on the presynaptic neuron. Remember, these are the autoreceptors that are detecting when we've released enough norepinephrine, right? So, okay, we have enough norepinephrine being released here, we're going to shut down further release. So if I have something that activates this on its own, remember what the term for that was? It's a sympatholytic, right? Because it's actually decreasing the sympathetic tone, as opposed to something like a sympathomimetic, which would be increasing it. So if I gave someone norepinephrine, that'd be a sympathomimetic. Something that activates alpha-2 is actually going to be sympatholytic. So I'm decreasing sympathetic tone. So what would I expect to see from that? So would I expect to see sweating? No, that's going to be more of a sympathetic stimulatory sort of effect, right? So that would not be the case. Hypertension, would you expect to see hypertension? No, because I'm having less norepinephrine being released. So what is that? What receptors would that mainly be affecting? Remember, alpha-1. Alpha-1 is going to be the primary one that's going to be causing things like hypertension. So in this case, I actually can use these sort of substances as an antihypertensive and actually drop blood pressure, because I'm actually decreasing the alpha-1 stimulation there, right? So it expects the hypotension as a result of giving something like this, okay? Now, how about on the heart? What am I going to be inhibiting? So less norepinephrine, so which receptors are not being stimulated now? Beta-1, right? We said beta-1 is a primary mover and shaker on the heart there from a sympathetic standpoint. So if I'm decreasing the activity and the release of norepinephrine onto the beta-1 receptors, would you expect to see tachycardia or bradycardia? Bradycardia, you expect to definitely see that, because now that tone has gone down, and now maybe the vagal tone is going to be more predominant. You're going to see bradycardia associated with that, right? But on the flip side, if I'm decreasing norepinephrine activity in the eyes, you can typically see is going to be more meiosis, right? Because again, sympathetic activation is going to cause what? Going to typically cause my dry eyes. It's going to cause those radial muscles to contract and pull the iris apart, and so that way you're going to find those big midriatic pupils here You're going to expect to see meiosis because now you're not necessarily constricting contracting the circular muscles, but you're relaxing those radial muscles that will cause that meiosis to happen. Okay? All right. A beta-1 agonist would cause which of the following? Hypotension, bronchodilation, tachycardia, or urination? This one should be relatively straightforward as I just gave away the answer. Fantastic. Good. So what would cause hypotension from a sympathetic standpoint? What activation of which receptor? Typically beta 2. Remember, beta 2 is going to have vasodilatory sort of effects. It's going to cause relaxation of the endothelial smooth muscle there, right? So that's why you see a little bit of hypotension associated with that. So it would not be the case there because we're talking about beta 1 activation primarily. Okay, bronchodilation. What do you see? What would cause that? Again, beta 2 stimulation, right? Because it's causing relaxation of the bronchial smooth muscle. It would also not cause urination because typically beta effects on the bladder should do what? Should relax it, right? And again, that's going to be more beta 2 effects there. But the heart is, again, the beta 1 capital, so to speak. And so you're going to find that it's going to typically cause tachycardia when I have an agonist, right? Now, if I put a beta 1 antagonist, what would have been the right answer? Bradycardia would have been the right answer in that case, right? Good. All right. You guys aren't as like talkative as you normally are. Which part of the brain is especially important in the formation of memories, such as this awesome Kahoot we're going through right now? Would it be the hippocampus, the hypothalamus, the cerebellum, or the amygdala? Anyone ever play that game Bloodborne by any chance? They say amygdala in that game, which I thought was a very odd sort of pronunciation, but I say amygdala. Good, yeah, the hippocampus is the main player there. The hypothalamus, we know, is good for regulation of things, right? It's going to be able to regulate all those vegetative functions and whatnot. The cerebellum is used for what? Coordination of movement, sequencing of movements, things like that. Good. And then the amygdala is good for what? Yeah, more like kind of baseline emotions, kind of those like anger responses and things like that. Typically going to be maintained through the amygdala. The hippocampus, where we're going to see the memory stuff. And again, that's associated with which association area? The limbic area. Yeah, the limbic area is going to be important for that. Right? Good. Okay. Which portion of the cerebellum is involved with movements of the hands and feet? Is it going to be the vermis, the lateral or intermediate zone, or the lateral zone here? Interesting. Okay, let's look at this. Okay, so remember what is being controlled with the vermis? Think about this as being like associated with our body. So right in the center here, we have all the axial sort of muscles and things like that. So this is good for like postural muscles and whatnot, right? In this intermediate area, that was going to be, what do we see there? Control of the distal limbs, the hands, the feet, etc. Right? So that's good for that. And then this lateral zone is going to be better for like more like communication of signals and whatnot. Again, not any particular area that's going to be coordinating the movements of necessarily. Okay, so just remember that. Again, it's all going to be the axial muscles. And this is all going to be like hands, feet, distal limbs, right? Okay. Which of the following is false regarding synaptic transmission? Neurotransmitters can be metabolized or taken back up by the neuron. Autoreceptor activation decreases neurotransmitter release. Activating voltage-gated calcium channels triggers neurotransmitter release. Or communication is often two-way. All right, so let's look at this. So neurotransmitters can be metabolized or taken back up by the neuron. Absolutely, right? So we can either metabolize it right there in the synapse, or there are reuptake transporters, right? So we have those for things like serotonin and norepinephrine, how a lot of our antidepressants work by blocking that. So yes, absolutely, we like to be efficient with our neurotransmitters and either metabolize them or be able to recycle them back up into the neuron itself, okay? We talked about autoreceptor activation. That decreases neurotransmitter release. Remember, those are going to be off on the side where once they get activated, once levels of those neurotransmitters are high enough in the synapse, it can feed back and it activates that negative feedback loop saying, hey, we have enough. Let's go ahead and shut down further release of those neurotransmitters. Okay. Activating voltage-gated calcium channels triggers neurotransmitter release. Very frequently, this is what's occurring. So you're going to find the action potential will travel along the neuron down to the synapse. You're going to find that you will have voltage-gated calcium channels will open up, and that will stimulate release of those vesicles into the actual synapse itself. Okay. However, communication is often two-way. This is false. There are some cases where you're going to have communication that is two-way, but more often than not, it's going to be going from one neuron to the next, to the next, to the next, right? And we like that one-way communication because that prevents from having these kind of reverberating signals kind of coming back in the wrong direction, and we can't transmit signals appropriately in those cases, right? So again, it's going to be, you have all the dendrites are going to be getting signals coming into it, travel, sends the act potential down the axon. Again, that's a one-way sort of transmission there where they can send a signal to the next neuron, okay? All right. What powers muscles for the shortest period of time? It would be ATP, glycogen, phosphocreatine, or oxidative metabolism. Just say skeletal muscle in this case. This one may be a little tricky, but good split here. Okay, at least most people understood that oxidative metabolism is kind of taking the longest amount of time, right? So it's going to be, while probably the most efficient in terms of generating energy as far as the number of ATP produced for every molecule of glucose coming in, pretty efficient. However, not the quickest thing we're going to have here. However, when you actually see muscle activation, we'll have some baseline level of ATP around that gets blown through very quickly. So you're going to use that up very quickly, and then skeletal muscle is going to rely on what next? The phosphocreatine tends to be the next quickest use, right? So this is good for just a few seconds of activation here, because again, phosphocreatine is going to be able to donate molecules to generate what? ATP. We got to have ATP there, right? Without ATP, the muscles just don't function. So phosphocreatine will be able to generate some ATP, but only good for a few seconds. And then where does the muscle go to? Glycogen. That's when the glycogen will start to break down those energy stores that the muscle has saved up. And by breaking those down, eventually you're going to both form ATP. You're also going to regenerate some phosphocreatine that can be used again for kind of intermediate sort of term muscle contractions, and then you have to fall back to the slowest, which we mentioned is oxidative metabolism there. Okay, so again, different muscle fibers are going to be able to use these differently. So for instance, you have things like the red muscle typically likes to use what more? Where those are better for long-term sort of contractions because they're red because of what do they contain? Myoglobin, right? So they like to carry a lot of oxygen. That means they're really good at oxidative metabolism. Those are good for like those kind of marathon sort of muscles, right? Versus if you have more of those fast twitch fibers, the white muscle, they tend to be much better at having glycogen stores and utilizing that and phosphocreatine, et cetera. But they're not really good. They get tired out pretty quick as compared to the more kind of the slow twitch sort of fibers there. Make sense? Okay. A norepinephrine reuptake blocker would cause which of the following? See, dry skin, bradycardia, hypertension, or meiosis. So blocking reuptake of norepinephrine. Good job. Yeah, so let's look through it. So we're blocking reuptake of norepinephrine. So that means norepinephrine levels in the synapse should go up because we're blocking the reuptake, right? So it's just not, they can't be recycled as efficiently. So more of it's going to be staying out there in the synapse, which means sympathetic tone should also go up. So we should expect to see more sympathetic effects body-wide. Okay, so what does that mean? So for the skin, what would that cause? More diaphoresis. You wouldn't expect to see dry skin because of that. How about bradycardia? No, because we're releasing more norepinephrine means more activation of which receptor? Beta 1, so you'd expect to see tachycardia. Good. Meiosis, you'd not expect to see that because now we have more norepinephrine causing contraction of which muscles? The radial muscles, right? So you expect to see mydriasis. Good. However, the hypertension is absolutely what you would expect to see there because now you have more activation of the which receptors? Alpha 1, right? Alpha 1. So by causing more activation of alpha 1, that's going to cause more smooth muscle constriction of the blood vessels. You expect to see hypertension. Now, again, clinically, this becomes important when you're trying to decide what the best, say, for instance, drug is for your patient. So imagine I have someone who has a history of depression and hypertension. I have them coming in. I have a couple different options I can give them, one of which is a norepinephrine reuptake blocker. That might not be the best choice for my hypertensive patient because if this can worsen hypertension, guess what? I'm just going to be kicking, I'm just basically fighting myself as far as medications go. So you can have patients who maybe, they come in to see the family practice person, they get prescribed an antihypertensive, and then they go see their psychologist or psychiatrist, and they get prescribed this norepinephrine reuptake blocker, and they come back to you, and all of a sudden their blood pressure is still high, and you're like, well, what the heck? It was working well for a while, now it's not. Again, this is why you need to figure out, okay, well, are there other meds that are on? Has something changed? What's going on here? And you can try to figure out these sort of pieces, and then you can we'll say, let's try a different drug, or maybe we'll try something else for treatment of that depression, right? So these are all things you want to consider. What is the function of ATPase in muscle contraction? I should say skeletal muscle contraction. It causes the cross bridge to form between actin and myosin. It causes the power stroke that moves actin along myosin. It causes myosin to dissociate from the actin filaments, or it causes myosin to assume the cocked position. All right, so let's walk through this, see what's going on here. So remember, when you have initially, let's say we're starting at a baseline. So think about the myosin head. Attached to it right now is going to be ADP and a phosphate group, right? Because initially when ATP binds to it, remember the myosin head has what kind of activity? It has ATPase activity. So it's able to cleave that ATP into ADP and phosphate. So let's say we're already in the cocked and ready position. What's going to come along and cause those active sites to be available on the actin? Calcium will come in. Calcium being released from, say, the sarcoplasmic reticulum will come in, will bind to that troponin C. It will then cause that conformational shift to occur where ADP molecules are now available. Okay, that will cause an attraction between that phosphate group on the myosin head. It will cause an attraction to the actin. That's when you actually have the binding occur here, and that's when the power stroke happens. That's when you have the actin moving along the myosin, and that's when the actual contraction happens. Okay, now how do we reset that? Well, basically the ADP and the phosphate are going to come off of the head, right? So that's going to cause a dissociation there. The ATP is going to then bind to it. It's going to get it back into the cocked position, and then that gets cleaved, and now you're ready to go again. Make sense? So go back and look at those graphs, kind of see what's going on step by step, so we kind of understand what's happening with that. Okay? You're with me? So if you want to go back and review that, that's fine. Okay, let's say we're slowly lowering a barbell after a bicep curl. This is considered what type of contraction? Just for reality's sake, just imagine he's in the squat rack right now doing this at the gym. Oh, right? The worst. There's only 2 of them here, and you're doing your bicep curls? Come on. Come on. Yes, sir. Yes, oh, sorry. Is it isometric and concentric? Is it isotonic and eccentric? Is it isometric and eccentric? Or is it isotonic and concentric? I was too busy making a joke, and I didn't even read the answer choices. I apologize. All right. So let's go through this. Okay, so we're on the descending phase here. We are lowering the barbell, not dropping it, but we're just lowering it slowly. So is that concentric or eccentric?
Eccentric.
Eccentric, right? So concentric, think contract, concentric, right? So that would not be the case. We're lowering the barbell. So this is going to be the eccentric phase of it, right? So we still need muscle contraction to occur throughout that. It's relaxing as you go down, but you still need it to occur, because otherwise, if everything just relaxed all at one time, guess what? That's when you drop it all, right? And that's no good. So in this case, okay, we know it's going to be eccentric. The question is it isotonic or isometric? What's the difference? Well, is the length of the muscle changing at all? The question is, we're lowering the barbell, so is the length changing? Yes. So does that mean it's isometric? No. So we're keeping constant tone in the muscle, because that's how we're lowering it down nice and slowly. That's going to be more isotonic. Isometric means it's not changing size at all, right? So imagine you've had something like you're doing a dead hang from a chin-up bar or something like that. You're just hanging there. You're still having muscle contraction. That's what helps to keep yourself stable there. But there's tone there. Tone may be changing, but there's no actual change in the actual muscle length, as the case may be. In this case, we're finding it's going to be isotonic. The tone of the muscle staying consistent all the way throughout. However, the length is changing. That make sense? Okay. What is the function of the microglia? Does it phagocytize foreign materials? Does it secrete cerebrospinal fluid? Does it form the blood-brain barrier, or does it form myelin sheaths? You can definitely tell a difference when we do this after a lecture, because I see you guys are just like way more worn down than if we just like come into a review fresh, but that's okay. You can go back and review this if you need to for posterity's sake. Okay, yes, so the microglia are going to be able to phagocytize foreign materials there. What secretes the CSF? There's those ependymal cells. Those will actually secrete CSF, located kind of like along the line of the ventricles there. Does not form the blood-brain barrier. What did that? Those are the astrocytes that did that. So astrocytes help to form that blood-brain barrier. They have those nice little legs that kind of go in, kind of encirculate, encapsulate the blood vessels there. And they do not form the myelin sheaths. What do that? Oligodendrocytes will do that. And then peripherally, what will form the myelin sheaths? The Schwann cells, right? Okay, when would the force of muscle contraction be weakest? When actin does not overlap myosin, when myosin is 100% overlapped by actin, myosin is 50% overlapped by actin, or the Z disc begin to crumple ends of the myosin filaments. When would the force of muscle contraction be the weakest? Good, yeah, so if there's no overlap, can you have a contraction at all? No, yeah, there's nothing, the actin and the myosin can't ever associate with one another. It can't cause any force of contraction at all. So again, no force there. That would be the absolute weakest. Now, what would be the strongest, do you think? Probably the 100% overlap between the actin and the myosin. That means that all the binding sites of the myosin should be able to interact with actin, should get a pretty strong force of contraction with that one. And then it would tend to weaken again once you get to what point? Once the Z disc start to get, because again, remember the sarcomeres kind of get from Z disc to Z disc. As you have that start to contract in, as the sarcomere contracts itself, you can get to a point where the Z disc will start to crumple in the myosin, and then now you're losing an active site for the myosin to bind to actin, and thus you can start to see a little bit loss of contraction there. So again, if you were to look at that, if you go back to the slide we had, just say new, don't save. If you were to look at that graph and actually looking at the force of contraction, you would see that at the lowest point, this would be when you have no overlap whatsoever. As you start to see more overlap, it starts to go up, and then it kind of peaks out. And then once you start to see it crumpling, that's when it would start to go back down again, right? Because again, you're losing active sites at that point. Okay. When a neuron develops an action potential after it has been excited by multiple neurons, this is known as temporal summation, spatial summation, TREP, or fused tetanus. So we're developing an action potential after it's been excited by multiple neurons. Temporal summation, spatial summation, TREP, or fused tetanus. Or tripe, or however you... It's definitely not tripe. Anyone ever had tripe before? And they're pho, perhaps? It tasted fine. No pho fans? No one? Okay. All right, so this is called spatial summation. What would be temporal summation? Yeah, because I got the same synapse kind of firing multiple times in order to kind of build up enough of a threshold in order actually to get the action potential to occur here, right? Now, again, you can have both of these going on at the same time depending on what the situation is in the neuron, but when you're talking about repeated firings by the same neuron, that is going to be temporal summation because it's all happening within a short period of time. Spatial summation is a bunch of neurons all firing in a concerted effort to try to get the action potential to occur there, okay? When you see that TREP, what is that? That's a step-like effect, and when you're looking at skeletal muscle contraction, as you start to recruit more and more motor neurons, right, they will start to see this kind of gradual increase in actual force of contraction there as you recruit more of those motor units. And then the fused tetanus, when is that? we're getting such quick action potentials to the muscle that it's able to stay at a contracted state for a prolonged period of time, right? So again, that fuse tightness is good because it's helping me keep my postural muscles and helping them to not just kind of give out all of a sudden and then I fall on the ground, right? What's the psychoactive component of these magic mushrooms? Is it nicotine? Is it lysergic acid diethylamide or LSD? Is it muscarine or psilocybin? So like a dozen answers go real quick, so I'm assuming you guys just were guessing and did not actually know that off the top of your head. Wow, not as many well-versed individuals as I would have guessed there. Yeah. So this is actually, when you think of magic mushrooms, typically we don't think of Amanita muscaria, even though that's where we get muscarine that actually interact with the muscarinic receptor. However, it doesn't actually cause the same kind of psychedelic sort of effects as you see with these sort of magic mushrooms. This is for no points as well, it's just kind of a little bit of trivia. But yeah, definitely not nicotine, definitely not muscarine, and LSD is actually, that's a synthetic chemical, so actually was made by man. As the case is. This is actually psilocybin. So it can actually break down the psilocybin, or actually form psilocybin, and this is actually what causes the psychedelic sort of effect where it can get cool vivid colors and the walls start moving, all kinds of cool stuff. Exactly, yeah. So there's different types of mushrooms that can have different components to them. But again, I'm not going to put a picture of a mushroom on the test and ask you to tell me what the active component is. However, I would expect you to know that, hey, I say muscarine is a muscarinic receptor agonist. What effects could you expect to see? That could be a question, right? This is more just for fun because I like to talk about mushrooms. Some people have termed me a fun guy because of it. Mm-hmm. Okay. A skeletal nicotinic blocker would cause which of the following? Dry mouth, paralysis, urinary retention, or decreased gastric motility? Skeletal nicotinic blocker. Speaking of psychedelics, does anyone know what it's called when you start to conflate your varying senses so that you can see smells or maybe you hear colors? Know the term for that? Synesthesia, yeah. So if you ever hear that, it's a common psychedelic term. You can see that basically you're mixing up your different sensory inputs. Yeah. So okay, going back to the skeletal nicotinic receptor. Okay, so we'd expect that from blocking that, what could I not generate? I couldn't do muscle contraction, right? So again, when you think about things like people undergoing surgery or they're getting intubated, you're giving them a nicotinic receptor blocker. Now, it's not non-specific and affects every nicotinic receptor across the body. That would be bad. But it's actually a skeletal nicotinic receptor blocker. So then there can be some specificity here, which is good because in this case, when I'm getting a patient down for surgery, I want them to not be moving around on me. I want it to just affect those skeletal muscle receptors. So again, dry mouth would be more of a problem that you would expect to see with, say, a muscarinic antagonist. So that would not be the case here. You would not expect to see urinary retention. However, you can certainly see that if you have a muscarinic blocker on board, but this is not what we were asking. And then also decreased gastric motility. So all these things you'd expect to see from a muscarinic blocker. However, we asked very specifically about a skeletal muscle nicotinic receptor blocker, and so in that case, that would be paralysis. Okay, make sense? All right. Catecholamine O-methyltransferase metabolizes which neurotransmitter? Is it GABA, dopamine, acetylcholine, or glutamate? Catecholamine O-methyltransferase, or COMT. Good. So think back, what are catecholamines? The neurotransmitters that fall into that category are going to be your norepinephrine, your dopamine, and your epinephrine. Those are catecholamines. And so you can kind of link those back to this enzyme, catecholamine O-methyltransferase. This is a metabolizing enzyme of that. So had I put norepi or had I put epi on here, those all would have counted as being metabolized by this. GABA is not going to be metabolized by this. Actually, there's a GABA transaminase that would affect that. Acetylcholine is metabolized by acetylcholinesterase. Glutamate, there's like glutamic acid decarboxylase, actually helps to convert over into GABA. That gets outside of our roles here. But again, COMT metabolizes these catecholamines. What else could have metabolized dopamine that we talked about? Starts with an M. MAO, monoamine oxidase, right? So you think back to MAOIs. If you've ever heard of those old school antidepressants, that's what they're doing is they're blocking the breakdown of things like norepi and dopamine, etc. Okay. When contracting the bicep, which of the following events is occurring? The gamma motor neurons cause the muscle spindle to elongate. The alpha motor neurons fire at a decreased rate. The alpha motor neurons cause the muscle spindle to shorten. Or the Golgi tendon organ cause the muscle spindle to elongate. So we are contracting the bicep. And again, this is conscious stimulation saying, hey, contract your bicep, lift up this barbell, whatever happens to be. All right, so let's work through this, right? So it's important to understand these reflex pathways and kind of how we can prevent the reflexes as the case may be. So for instance, normally imagine this was an unconscious shortening of the bicep. So say for instance something's coming along and just shorten up that bicep. Normally what would happen to the muscle spindle? So the muscle's getting shorter. I'm not having any kind of innervation coming from the brain, so what's going to happen to the muscle spindle? It'll get shorter too, right? So that gets shorter. What is the reflex at that point? It wants to elongate it, right? So it's going to send a signal up through the spinal cord back to those alpha motor neurons. This is, hey, you need to elongate the muscle. We want to keep this tone pretty consistent here, okay? That's normally what the reflex is. Now, if my brain's telling the bicep to contract, I want to make sure I prevent that reflex from occurring here, okay? So what is responsible for changing the length of those muscle spindles? So if you go back to the picture, what was it? Was it the alpha motor neurons? That wasn't the case because that was actually what's stimulating the muscle to contract in and of itself. It's these gamma motor neurons, right? The gamma motor neurons are going to pull the muscle spindle at either side when they're activated, so that way I can elongate the muscle spindle. So if my brain is telling the bicep to contract, that's going to shorten the muscle. However, and again, how does it shorten the muscle? Well, it's going to activate those alpha motor neurons, but at the same time, I'm activating the gamma motor neurons to stretch out that muscle spindle. So even though the muscle is getting shorter, the gamma motor units are going to be keeping the muscle spindle elongated to keep it roughly the same. So that way I don't have that reflex arc feed back in and say, hey, you need to relax that muscle there. Make sense? So in this case, this is why the gamma motor neurons cause the muscle spindle to elongate. That is in order to prevent that reflex from kicking in. Make sense? Everyone with me? Can we walk through that again? Perhaps? Okay. So looking at this, if my brain is telling the bicep to contract, I'm going to be stimulating the alpha motor neurons. That's going to be causing the muscle to shorten, right? Because when I send a stimulatory signal here, I'm going to shorten the muscle. Normally, this would shorten the the muscle spindle here to stimulate the sensory fibers, but to counteract that, these gamma motor neurons are going to be firing at the same time the alpha ones are. So even though the whole muscle is shortening, by pulling the muscle spindle at either end, basically kind of pulling it apart, you're going to elongate it, and that will prevent that reflex from occurring. So roughly, the size here should not change at all. Even though the muscle is contracted now, this should be pulled on either end to keep it the same length.
Answer also right? The yellow one?
The yellow one. So alpha motor neurons cause the muscle spindle to shorten. No, because the gamma is counteracting it, right? So again, even though the alpha motor units would cause the muscle spindle to shorten, you have the gamma motor neurons that are going to be preventing that from occurring. So they're kind of counteracting one another to prevent the reflex from occurring.
There's no net change, right?
There's no net change in the size, right? Because that way I don't stimulate the reflex.
So the gamma is making it longer while the alpha is making it shorter.
Exactly. Yeah. So the alpha is making the muscle shorter, but the gamma is making the muscle spindle longer. So they counteract one another, and there's no net change in the size of the muscle spindle. Okay. So you work through that a few times, kind of understand what the reflex pathways are. Imagine if you had a case where there's no alpha motor neuron stimulation. So again, the brain's not doing anything. So for instance, if I stimulate if I elongate these quadriceps by hitting the patellar tendon, where does that reflex, right? That is without having any kind of direct stimulation there of the alpha motor neuron. That's just a reflex arc in the spinal cord. Versus if I'm actually stimulating, say, hey, you need to straighten out your leg and activate the quadriceps. Okay. Now the Golgi tendon organ, what does that do? That's only going to be stimulated when you have stretching of the muscle, because those are located on either end at the actual tendons themselves, right? That's where it gets attached to the muscle or to the bone. When you have stretch of those, that should cause a reflex what? A reflex relaxation of the muscle, because if I'm stretching those tendons really hard, what is the risk if I stretch it too hard? I'm going to cause an avulsion. I'm going to cause that tendon to rip off of the bone itself. Okay, you don't want that to occur typically. Typically, you want to keep everything attached. So the Golgi tendon is going to have a reflex. It'll say, hey, let's just go ahead and relax this. Now, if you remember, the muscle spindle can either have inhibitory reflexes or stimulatory reflexes, depending on if the muscle is getting longer or shorter. The Golgi tendon is only going to be activated, and it's only going to be inhibitory when that tendon is being stretched. Okay, just kind of keep the functions separate in your mind there. Okay. Moving on. Which area of the cortex is involved with the most simple motor patterns? Would it be the primary motor cortex, the basal ganglia, the premotor cortex, or the supplementary motor cortex? Okay, so the primary motor cortex tends to have the most kind of rudimentary sort of movements associated with them. If you go back and look at the, I don't want to show the picture of the brain because I kind of gave it away if I had everything labeled up. But the primary motor cortex is kind of the most kind of baseline, simplest sort of movement patterns. As you get into the supplementary in the premotor cortex, that's when you're going to get more kind of complex movement patterns of things like, more distinct movements of the hands and other kind of complex things. The basal ganglia is good for like kind of sequencing several movements out, right? So you can kind of coordinate things like walking over and flipping off a light switch or whatever it happens to be. Okay, those are a little bit more complicated. A lot of this stuff will get fed into the primary motor cortex, and then that can then travel through which tract? You guys remember? Where the pyramidal tract is where you have a lot of that coming from the cortex. You also have the extrapyramidal tracts that can be useful from other places as well, but that's kind of the main thing there. Okay, so kind of know what kind of the functions of the different areas are going to be here. A non-specific beta blocker, which means it affects beta 1 and beta 2, would cause which of the following? Tachycardia, diarrhea, diaphoresis, or bronchoconstriction? So I'm blocking beta 1 and 2 equally. It is a non-selective blocker. Interesting. All right, pretty even split here. So let's look at this. We're blocking both beta 1 and beta 2. So would you expect to see tachycardia if I'm blocking beta 1? No, you'd see bradycardia if anything, right? So that would not be the case here. Would you expect to see diarrhea? Not necessarily, because if I'm blocking the effects there, you don't really see a overstimulation of the GI tract. So diarrhea wouldn't necessarily be a common thing you would expect to see with that. Diaphoresis? No, because again, also you're kind of blocking those beta effects. You do not expect to see a lot of sweating associated with that. However, could I see bronchoconstriction? Because what is normally causing bronchorelaxation? Usually beta 2 receptors, right? So again, this is a problem you can run into if I give someone who, say, is an asthmatic patient who's really dependent on having that beta 2 relaxation, and I give them a non-specific beta blocker, I can actually block those beta 2 receptors, and all of a sudden I can cause bronchoconstriction. So I can actually induce an asthma attack in those patients. And typically, do you want to give your patients an asthma attack? Often, no, you don't. You'd like to keep your patients breathing. That's usually part of the ABCs, right, of keeping people alive. Airway, airways A. First thing, want to keep them breathing. So yes, you would definitely be concerned about causing bronchoconstriction. And again, the only way to correct that, I have to give a beta 2 agonist to actually cause that relaxation to occur again, which I'm already blocking, so that can be a problem. But anyway, so that makes sense. If I have a non-specific blocker, it just means I'm blocking both beta 1 and beta 2. There's no delineation there. Okay. Which area of the cortex will be involved with planning out steps to perform a math problem? Be the cerebellum, the secondary somatosensory area, the prefrontal association area, the limbic association area. So say, for instance, you were doing a calculation for your for a PEDS prescription for amoxicillin or something. The separate steps you have to take. Okay, I'm going to go and take the daily dose and multiply it by their weight, and then I'm going to divide it by the concentration and blah, 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 all that good stuff. What is doing that? Yes, the prefrontal area. Remember, this is those cases where if you lobotomize a patient or you sever that connection between the prefrontal area to the rest of the brain, oftentimes they could not kind of reason through multi-step problems, and oftentimes they're very reactive to things, usually kind of reactive in a very kind of inappropriate manner, because things like ethical codes and moral rules of society and things like that tend to be kind of processed there through the prefrontal area. So that would be the case there. We mentioned the limbic area is good for what sort of functions? Emotions, baseline vegetative functions like hunger, satiety, things like that. Cerebellum we mentioned is good for like movement patterns, especially like sequencing out of movement. So if I had to flip my hand over, back and forth, over and over again. And then secondary somatosensory is just kind of picking up sensory signals up from various parts of the body there. Okay, make sense? Okay. Which type of brain waves are you likely having right now? Alpha, theta, beta, or delta? I hope you're having these brain waves. Perhaps you're not, though. Who could say? And how would we actually pick up these signals? What would we use? EEG, an electroencephalogram. Did you hear about the patient who got put on electroconvulsive therapy for their refractory depression? They had shocking results. Okay, so let's look at this. So, going back through, a lot of people said alpha waves. The correct answer is beta waves. Then let's see who said theta and delta. There's a few of you. I hope you're not having theta and delta waves. That would be very, unless you're sleepy, then that makes sense. But let's talk about the different waves, though. Okay, so when I'm just kind of at a baseline of awake, sort of restful state, what kind of waves am I probably having predominantly? those are going to be your alpha waves, right? So remember that those are typically, remember they're smaller in amplitude than something like your theta or the delta waves. And the reason why their amplitude is usually lower is because of what? There's a lot of action potentials going back and forth across the brain there, so you're going to find a lot of those will cancel out. So because they cancel out, you're going to see that the amplitude is pretty low for the most part. However, you will see that the frequency of waves is very high because, again, you have a lot of neurons that are all firing off. Okay. Now, if I wanted to focus my attention onto something and actually focus really intently, say, for instance, trying to answer a Kahoot question actively, that's when you're going to develop what sort of waves? More the beta waves. The frequency goes up even higher because you're actively concentrating on something. You're actively thinking about something. So the number of action potentials you're seeing is going even faster, right? Typically, you're going to see a lot of these like start to pop up around like REM sleep and things like that when your brain's kind of actively going. Now, as you say, for instance, if you were to go to sleep, maybe you're starting to doze off a little bit right now. Perhaps you're developing some theta waves. As things start to slow down a little bit, you're going to see the frequency gets slower. You're going to find that the amplitude is going to go higher because you have less neurons that are counteracting one another. And then for some of you, if you develop a very deep restful state, that's when you end up hitting the delta waves, right? Or for instance, if you had no brain function whatsoever, then you probably end up having a lot of these delta waves that will be developed there. Make sense? So again, beta waves are more have a higher frequency than alpha waves when you're having direct active attention on something. Okay.
Would we have to distinguish this on like a picture?
I would not ask you to, because again, if you had me do that on a test, I would probably get it wrong as well. I don't expect you to be a neurologist by any chance. But again, like, we have to read reports of things, right? So again, if I am looking at a patient in the ICU and they're evaluating them for brain death or not, so to see whether or not they're maybe a candidate for either maybe pulling life support or if they're going to be an organ donor, this is oftentimes what they'll do is they'll hook up an EEG, they'll look for these things, and the neurologist will report out on things like, hey, there's a high preponderance of delta and theta waves here. There's really no alpha or beta. This would lead me to believe that the patient is in fact brain dead, something like that. Versus, just like, if you ask me to read a chest X-ray, unless it's something super obvious, I'm probably not going to tell you much. But I can read the radiologist report. I can read that and get a whole lot of information. And being able to take that and interpret and do something with it is what's more important here. That's what I'm trying to kind of focus on for our purposes for this class. Okay. Good. And remember looking at that one picture where it was showing you where the eyes were closed, you saw a lot of alpha waves, and then as the eyes opened up, you saw the beta waves as you start to take in all that visual information. And then when they closed again, it went back to the alpha waves. You kind of use that as kind of like kind of your guiding principle there for kind of thinking about it. Okay. Which neurotransmitter in midbrain area would assist with promoting sleep? Would it be serotonin in the raphe nuclei, acetylcholine in the reticular formation, norepinephrine in the locus ceruleus, or dopamine in the substantia nigra? What do we think? So promoting sleep. If it helps, think back to Thanksgiving dinner. Maybe helpful. Good, yeah. So remember, serotonin typically is going to have more sort of inhibitory sort of effects on kind of global activity of the CNS. Think of the turkey you're eating. It's got a lot of tryptophan that turns into 5-hydroxytryptamine or serotonin, 5-HT, and then that's going to be coming from the raphe nuclei, typically to promote sort of restfulness, right? Acetylcholine is going to be more stimulatory or inhibitory? Well, it doesn't promote sleep, so it probably is going to be stimulatory, right? And those are good for kind of quick burst of increases in awareness, right? So say, for instance, like you're driving your car and you're kind of drifting off a little bit, and all of a sudden you drive off the side of the road, you hit those little bumps, and then all of a sudden, oh, I'm back. Acetylcholine is probably responsible for some of that, right? Norepinephrine, probably inhibitory or stimulatory? Stimulatory, right? Think norepinephrine, think sympathetic, think, okay, we're activated, right? And then dopamine can kind of have some inhibitory, some excitatory effects. It just depends. But again, it's going to be more focused on a lot like movement patterns and things like that, okay? All right. Which of the following would occur after placing your left hand on a hot stove? The left tricep would contract, the right bicep would relax, the left bicep would relax, or the left tricep would relax. This is going back to those reflex pathways. So I put my left hand onto a hot stove. Certainly there would be signals going to the CNS that would cause my Broca's area to utter certain words, I imagine. All right, so let's work through that. So imagine I put my left hand onto a hot stove. What's my first reflex going to be? Pull your hand away from the hot stove, right? So my left tricep should be relaxing, right? Because again, your triceps is an extensor muscle, so you expect that to be relaxed. The bicep on the left arm should contract, so I'm pulling it away. And then the reflex.
The left tricep relaxes is one of the answers.
Did I put that on there?
Yeah.
Well, I guess all you guys are right too. This is like, whose line is it anyway? The points actually don't matter, so. But let's work through it. I apologize for that. I am fallible, just like all of you. I imagine you'll have to extend me some grace there. But the reflex, so from the left arm, so then going over to the right arm, what does that want to do? Extend out and contract the right tricep, but then relax the right bicep there. So that's why I put right bicep relaxed, but obviously I was tired when doing this and was not thinking thoroughly. I was probably having some theta waves going on, and I forgot to click the button to say that was right as well. So good job. All of you can answer green. Okay. Which of the following is false regarding neurotransmitter synthesis? GABA gets turned into glutamate, norepinephrine gets turned into epinephrine, tryptophan gets turned into serotonin, and dopamine gets turned into norepinephrine. Which one of these is false regarding their synthesis? Good. All right, so going back, remember that along the pathway of synthesis, remember that things like tyrosine can be turned into things like L-DOPA. They'll eventually get turned into dopamine, and then from dopamine it can be turned into norepi. In the adrenal gland, norepi can be turned into epinephrine, right? So again, that would be true there. In this case, why is this false? Glutamate gets turned into GABA. Is actually opposite here, and that's important because if I were to inhibit this process, if I inhibited the formation of GABA and I had too much glutamate around, what could that cause? Remember, GABA is inhibitory, glutamate's overall excitatory. You can develop seizures, right? I have overstimulation, I have too much glutamate activity that can cause seizures in those cases. And again, what's the main way we stop seizures? With GABA. We need GABA to work better because it's going to help to hyperpolarize those cells by trying to increase chloride influx, all that good stuff. So that's a very important thing to consider there. Certain toxins can do this. Certain mushrooms actually can do that, for instance. But just know that glutamate will eventually get turned into GABA. Okay. So the winner is, in third place, SOS. Great job. Hopefully you get some help there. Mimi. Fantastic. Good job. And SP. Awesome, fantastic. You guys get your free answer. It is A. And all of you who answered green on that one, second to last one, also can get the answer A. I can give you a separate answer if you like. C. There you go. Okay, so anyway, so wrapping up the class, any questions I can answer before I finish up? I will appreciate all of your evaluations, please, as constructive as possible, unless you got really some big grievances to air out, and then let me be your whipping boy, as the case may be. I will probably not be teaching this class next year, so some of that feedback, just because I'm picking up research courses, so I'll have more classes with you in next summer. So boo, yay, whatever, whatever your feelings may be. That feedback is still important because whoever inherits this class can potentially benefit from that. It's always hard to inherit a class and do it for the first time. This is my second time doing it, which is why I felt much more comfortable with you guys than last year. But that feedback can be very critical. So if you thought something was like way too involved or not involved enough or whatever happened to be, just feel free to report that back. And then otherwise, test is Monday. So any questions you have, please get them to me before then. And that's it for the class. So thank you so much, and see you guys later.